afternoon, ladies and gentlemen, and thank you to the organisers for the opportunity to come and speak to you today on South Africa's experience with rolling out a new TB diagnostic tool, the Xpert. And as Katerina mentioned, I'm here actually speaking on behalf of Professor Wendy Stevens, who with apologies couldn't be here today to present. So just a little bit of background about the TB disease burden in South Africa. And this data is from the recent WHO report that was launched last week. So South Africa has the world's second highest incident rate of 1,000 in 100,000. Our mining populations and correctional services are the highest risk groups, with a very high incident rate, about 4% and 4.5%. So our main driver of TB is HIV, with 63% HIV prevalence in our incident TB cases. And as with many countries, our biggest problem is the missed cases. We have the world's second highest, as from the WHO report. Increasingly, our patients are smear negative, which is obviously a big problem. And South Africa reports the most XDR cases in the world, with annual notifications having increased from 467 back in 2009 up to just over 1,500 in 2012. And about 10% of all our MDR cases have XDR TB. So with that background in mind, and with WHO's strong recommendation in 2010 for the use of Xpert as the initial diagnostic test, our Minister of Health gave a call on World TB Day in 2011 for South Africa to implement the Xpert as the first diagnostic test as a replacement for all smear microscopy. So not only for MDR TB or HIV, but for all our presumptive TB. All right, so we began with the Xpert implementation. So this was one national plan because there were a number of donors and stakeholders that were involved. And in order for this to be a proper concerted effort, we need to have one national plan. As mentioned, the idea was to implement this in all of our microscopy centres, which at that time was 244. So we started a phased implementation, and now 2.5 years down the line, we have performed over 2.1 million tests, and we've procured over 60% of the global cartridge supply. So I'm very happy to say that we've actually reached 100% of our goal as of the end of September this year. And that was the set timeline. So we were quite successful in reaching 100% coverage of the national plan. So to date, we've placed 283 instruments. That's of varying different sizes. Most of our instruments are the GX16s, and we are about to purchase 7 of the large Infinity instruments as well to assist with our capacity. And that's in 207 centres. So as with the implementation, there are a lot of things that go hand in hand with implementation. It's not just about the technology on its own. So we obviously had to redefine the algorithm. Training was a huge part of the implementation. So we've trained almost 1,000 laboratory staff on how to use the Xpert, and just under 4,000 clinical staff on the algorithm changes and correct sputum collection. And then just to show, this is our placement of the Xperts around the country, and then in relation to the clinic facilities. All right, so as mentioned, we've tested over 2.1 million tests. That's since the 1st of March 2011. Our MTB positivity rate is about 13%. So this has decreased. When we first started the implementation, it was up at about 17%. And that was because we implemented first in the high burden districts. And we now think that the rate having reduced is also because we're actually reaching national coverage of the program. On the RIF-resistant rates, these have remained stable at about 7%. We do see some geographic variation, but more or less that's remained stable year on year. This is showing the uptake rate. So even though we did this in a phased manner over 2.5 years, the implementation was actually still quite steep. with an increase in volumes of about 10% every month. And our error rates have actually remained quite low. I know a number of other implementing countries have had very high error rates, but ours remained fairly stable, below 3% since implementation. So onto the algorithm. As mentioned, we needed to redefine our entire algorithm, and this is our current algorithm that we have, and there's been a lot of controversy. Is it too complex? So just quickly, it's very easy. If you're gene expert positive, RIF susceptible, you would be started on the first line regimen and then followed up with smear microscopy. However, if you're RIF resistant, you would then be treated as MDR-TB, and then you need to have your follow-up specimen sent for DST and LPA. Again, it comes in if you're gene expert negative but HIV positive, then the same route you would take. You would have another follow-up specimen for DST or LPA. So we do still perform a confirmatory test from the gene expert result if it's RIF resistant. So how does that confirmatory test, how does it match up with our RIF resistance results from gene expert? Well, the concordance we believe is quite good. On culture concordance, it's about 87%, and then on LPA, the concordance is about 90%. So we're happy with the concordance, but the problem that we're actually having is with algorithm adherence. So you can see the number of samples that we actually obtain to do the confirmatory test is extremely low. Only 9% for culture and 23% for LPA. So we're really experiencing extreme problems with getting that second sputum to actually do the confirmation. And the only province that we consider our role model is the Western Cape, where they have algorithm adherence of up to 72%. And the difference with this province is that they collect 2 sputums up front. And then if the gene expert is RIF resistant, the second specimen gets sent straight away for confirmatory testing. So a number of our provinces are going to be following the same route with this, and we'll most likely have an algorithm change. So what are the lessons that we've learned from Xpert? Well, as I said, it's not just the technology alone. There were a lot of things that went hand in hand with the implementation. And some of those things are a remote monitoring software that Xpert is busy implementing, which will allow us to monitor positivity rates, RIF resistance rates, error rates, and I think this is going to be very important going forward to monitor the program. Another initiative by Xpert is remote calibration that has been rolled out, which has saved a lot on costs and time. And then the NHLS has developed a verification and EQA scheme. We thought that this was very important for monitoring the quality performance of the test, and we're using this routinely now in all of our labs. There's also a lot of research that has been ongoing for other protocols, pediatric specimens and your extrapulmonary specimens, and impact studies that have been on the go as well. So beware of challenges when you implement a new test. There are a lot of other hidden costs. For example, training. We had no idea how much this was, the cost was going to be of rolling out all the training. As I'm sure most of you are aware, we experienced some stock shortages during the ramp-up phase, and then now we're experiencing module failures. So really it's recommended that warranty extensions or service contracts are taken out with these instruments. So another issue was the phased implementation. We had 2 algorithms going at the same time, and this did cause quite a lot of confusion at the clinics and also at the laboratory level. With the very fast rollout of the test in the laboratories, what we found was that training on the clinic side was lagging behind, and also this caused problems with algorithm adherence. And then mostly, as was already mentioned earlier on in the session, is that system strengthening is probably the most important thing. If you're going to be rolling out a new diagnostic tool, you really need to look at the systems first before you do that, because we have seen an issue with linkage to care. But just some outcomes from Xpert. Again, this is taken from the WHO report. So in 2012, South Africa had the third highest percentage of pulmonary TB cases that were lab confirmed, 71%. So this is compared to 57% globally. And we also had the second largest increase in the number of detected MDR TB cases. We also accounted for the most global cases for which second-line DST were reported. However, and this is a very big however, the treatment gap between those being diagnosed and those getting onto treatment has unfortunately widened. And as you can see here, this is the number of MDR cases that were notified from 2009. The increase, we're up to just over 15,000, and then cases enrolled on MDR treatment. So unfortunately, less than half are actually getting treatment. So where do we go beyond Xpert? Well, as mentioned, we do test with DST and LPA. With DST, by 2012, 95% of high-burden countries had reported incorporation of the WHO guidelines into their national guidelines. But globally, the laboratory capacity still remains very low. 22 out of 147 countries didn't have the capacity. And this is just a couple of publications on the performance of the second line LPA, showing different performances with the different second line drugs. One of which was poor for kanamycin. Unfortunately, we use kanamycin as one of our main second line drugs. And also that it hasn't been endorsed by the WHO yet due to suboptimal sensitivity in the fluoroquinolones and the injectables. All right, so other than the methods that we have at the moment, what is coming out? Well, Xpert, Cepheid is actually bringing out a new cartridge that is going to have additional markers. But again, will this be prone to some of the same characteristics that LPA suffers, in that there are just too many genes, it's too complex to do with a PCR assay. Next generation sequencing has been mentioned. And we do believe that this could be the way to go. In South Africa, the numbers would be manageable. We would have about 14 to 15,000 per year. Chip-based technologies or microarrays are also coming onto the market. And then nucleic acid testing combined with phage-based technology. There are also colorimetric culture-based methods. A true point of care test, I think we all agree that is greatly needed. And then assays for use in monitoring patients' response to treatment. So I'm not going to go into these because I'm sure this will get mentioned later on in the session, but these are just a few of the systems that are coming onto the market: the IQBate, Capital Bio, EasyNat, TrueLab, and the Alea. And we look forward to seeing the outcome of these coming onto the market. And just to acknowledge all of those that were involved, as I said, we had a lot of donors and partners that actually made this implementation possible. So just to thank everybody that was involved. Thank you.
Are there any questions? Maybe while someone steps to the microphone, could you just comment briefly, Leigh? We continue to hear that the case notification rate in South Africa has actually not gone up, probably due to the high number of patients empirically being treated for TB. So could you comment on that?
Yes, you're quite correct. We haven't seen the numbers go up, and I think you're correct in saying that, well, what we have seen is an increase in the laboratory diagnosed cases. But not an increase overall. So I think you're correct in that a lot of those were being empirically diagnosed previously.
Hi, two very quick questions. One, I noticed a very high variability in the concordance between the different methods per region, and it'd be interesting to hear why that might be. And the second is, using LPA, which measures something slightly different than Xpert, or using culture, which measures something slightly different. As a confirmatory test is complicated, What kind of data would the national program need to drop the requirement for confirmation?
Well, I think on your second question, we've found that we have very little RIF mono, so most of our cases are actually MDR. And we've also been looking at the actual probes that are used with the gene Xpert to see if picking up of some of those probes might be more indicative of MDR or of RIF mono. So if we do further research into that, then it might be possible for us to actually lose the confirmatory test and to go with the gene Xpert result on its own. And then your first question, yes, we do see some variation in the concordance. I think it might also just be the actual number that we've got, that it might not be statistically significant, just based on numbers in each province.
Is there any, you mentioned the lack of treatment in half the patients, but of those who get onto treatment, are they getting onto treatment more quickly since we're not waiting for is there any data on that?
I think there's some initial data that hasn't actually been published yet, so it's difficult for me to comment at the moment. I think some studies have shown, getting faster onto treatment. But as I said, I wouldn't like to put my head on a block at the moment. I think that the data is still unpublished at the moment.
Thanks a lot, Leigh.
Thank you.